Good evening, everyone. For the next series of UEFA medical webinars, we promised we are here to stay, and our third webinar shows that we are fulfilling our promises. Women's health is as important to our topics as education is. Before I pass floor to our excellent speakers today and our host, Evert Verhagen, I just want to say that for 100 years, we were trying to be same, men and women. We tried so hard that we, even in our heads, we became same, but we are merely equal. There are physiological differences, and from these physiological differences, there also comes pathophysiological differences. We need to respect now that these different differences do exist. We must remain equal in our rights, but we need to dedicate more research and education to the topics from women's health. And this is just one of many topics from women's health that we will have on UEFA webinars and medical symposium next year, which is happening from 4th to 6th of February, 2025 in Lugano. Save the dates, be invited to join there. More than 50% of this medical symposium will be dedicated to women's health. It is going to be part of Women's Euro pre-tournament events. Having said this, I'm passing floor to Evert Verhagen, our tonight's host.
Thank you very much, Zoran, and welcome everybody to this next edition of our medical webinars. Today we're going to talk about menstrual cycle in football. But before we do so, a few words, housekeeping rules. We must also say that we are supported by the European Club Association with these webinars. And in order to cater as good as possible as we can for you, we would like to let you know that we need to know which club you represent. So if you can put in the chat if you are representing a club, and if so, which club that would be, that would help us to modify the next topics of the webinars better to your needs. So that being said, let's go to today's topic, menstrual cycle in football. There's a little story to this topic. We were talking with some female clubs late last season, and we realized that there's a lot going on in terms of tracking of menstrual health, tracking of the menstrual cycle, and that many clubs were doing different things for different reasons and with different science on the background, and also using different tools to do so. And there was not really a consensus on who was doing what and why, and there were different reasons. So we thought, let's bring this all together. In the background, we're working on a consensus that should be finished before you start the next season on why we should track the menstrual cycle, what to track, how to track it, and what to do with that data. So stay tuned for that. And we thought in the meantime, it might be really valuable if we also have a webinar on this topic. And for that webinar, we invited Dr. Emma Paternotte and Professor Kirsty Elliott-Sale, which I will bring to the stage. Hi, Emma. Hi, Kirsty. Welcome today, and thank you so much for being with us. We're going to do it a little bit different this webinar. We're not going to have you two present for 20 minutes and have a 10-minute Q&A. You two prepared 3 cases for us, so it's a little bit of a challenge for us to organize this, but let's see how this goes. Emma will present a case to us. Kirsty will present a little bit of the scientific background to the case, and then we open the floor for a Q&A. And for that Q&A, we invite you all to put your questions into the chat box. We're monitoring that here. And then after each case, we'll have a brief session where we'll try to answer those questions in relation to this case. So without further ado, I'll give the floor to Emma, who will introduce you two better. I'm out for a few minutes, and I'll see you after the first case. The floor is yours.
Thank you so much, Evert Verhagen, for this introduction. Professor Kirsty and I will talk about female player and her menstrual cycle. But first, we will start to introduce ourselves so you know a little bit more about us. Kirsty, can you tell something about yourself?
Yeah, thanks, Emma. So great to be speaking with you all this evening. My name is Kirsty Elliott-Sale. I work at the Institute of Sport at Manchester Metropolitan University. This is our beautiful glass building here in Manchester, which is a shame because if you've ever been to Manchester in the UK, it rains a lot. So our building is like a giant waterfall all the time, but you're very welcome to come and visit us there. My role at the Institute of Sport is a professor of female endocrinology and exercise physiology. It's a very long title. Basically, I come from a sports science background. My PhD focused in exercise physiology, but specifically in women. And actually, for the last 25 years, my research has been exclusively in women, from elite sport all the way through to sort of women who exercise for sort of more health and physical activity. I'm very honored that I get to work with a lot of different sports and spend a lot of time within football or soccer. I'm not sure which we're calling it tonight. And it's a real privilege to be invited by UEFA to be part of this webinar tonight. And I'm really delighted and honored to be co-presenting with Emma. So Emma, over to you.
Thank you so much, Kirsty. Well, I'm Emma Paternot. I'm a gynecologist. I live and work in the Netherlands in a hospital over there. And I build a network where we see gynecological problems with female athletes, which could be very diverse, from having cycling problems, menstrual problems, but also pregnancy. I'm also the sports gynecologist for the Dutch Olympic Committee. And I have furthermore nothing to declare for this presentation. We will present for you 3 cases today, and I will start with the first case. Those are real cases which I've seen on my outpatient department as a sports gynecologist. And case 1 is a 21-year-old woman. She is a professional international soccer or football player. And she comes to my outpatient department because she has heavy menstrual bleeding, and this bothers her every month, especially when she has a match going on. I see this problem very often, but you can also see this problem in female athletes. There are a few things I would like to know when they come to my clinic. The first thing is, is the menstrual cycle regular, and how much is the amount of blood loss? We know that a lot of women think they do lose a lot of blood, but still in the end it's only like 50 to 100 mils of blood loss, which is normal. I always ask for abdominal pain during the menstrual cycle, which is called dysmenorrhea. And of course, a history. And this history is also needs to include questions about bleeding itself. So, for example, did you ever went to the dentist and had a longer bleeding period, for example? Contraceptives do have an influence on the menstrual cycle. So I really wanted to know how much blood loss you have. Do you use any contraceptive medication? Do you have a Mirena IUD or other IUDs? And also very important, what do you prefer? And the last question is if this heavy bleeding will cause anemia. Since you can maybe imagine that if your bleeding is that heavy that every month your hemoglobin will go 1 point lower, it will influence your performance in your matches and even in normal training activities. Kirsty is going to tell you a bit more about the background.
Thanks, Emma. So I'm just going to share with you some ideas now around some of the supporting research, or how we could research more into these topics. So when it comes to heavy menstrual bleeding, we actually don't have a lot of research around the effects of heavy menstrual bleeding on performance, especially in football, but actually in general in any type of women's sport. And this is for a number of reasons. So, for example, as Emma said, it's really important to know the volume of blood loss. And actually, we find that with some players that we've worked with and tried to do some research with, that they don't actually know what is normal. And so you can imagine, if this is not a topic that's being discussed openly within football clubs, then your point of reference, the player's point of reference is their own experience. So determining what is normal and what is heavy can be difficult for them. So we need to, of course, then change the conversation and raise awareness and educate around this topic. So from a research perspective, it can be very difficult to recruit participants, players, to research studies because they don't always know whether or not they have heavy menstrual bleeding. We also find it difficult because if we go to work with clubs and we want to do some research and understand this topic more, it's sometimes that the player hasn't reported it to the club. So maybe they know they have heavy menstrual bleeding, but they've been working on this issue with like a general practitioner, so the doctor they see away from football, away from the sport. And so maybe they don't know who within the club to speak to about it. So again, when we go in there to work with the players, to do some research, to understand how this might be affecting the players and performance, we don't know who to get this information from. We also need to understand, like Emma said, how is this being managed? So is there any type of medication or supplementation? Because again, from a research perspective, if you want to look at the effects of heavy menstrual bleeding, say on football performance, it may well be that we can identify some people with this condition, but if they're being medicated already or they're doing some type of intervention, it may then exclude them from the research. So actually it acts as a confounding factor. In terms of, I guess, some of the more practical implications within the club environment, so not specific just to the research environment, of course, players with heavy menstrual bleeding will need to consider things like uniform. I know, for example, certainly in the UK where I'm based, there's been a lot of conversations recently around players having to wear white shorts. I think, of course, this may cause some anxiety for any female player who menstruates, but particularly for those who maybe are suffering from heavy menstrual bleeding. So there might be some considerations around uniform. Of course, ideally, we want them to come forward and speak with doctors and work with people like Emma so that they're getting treatment for the problem, rather than just saying, let's put every female player in black shorts and hide the problem. So we have to think carefully about the issues around uniforms, whether or not we're helping in the long term or just in the short term. Maybe some other practical implications more within a club setting is around the availability of menstrual products. So of course, those players who are suffering from heavy menstrual bleeding may need different products. They might have a preference for different type of products. And again, are these being provided within the club setting? Or if they need to change their products more frequently, what happens if they run out of the products they've taken, say, with them from their own homes? So making sure that these products are available within the club setting will be quite important. And then even things like practical things like how often they need or get a toilet break. So again, thinking about that culture of who might know within the club that a player has heavy menstrual bleeding. Is that something that's built into the club environment? So how often are they offered a toilet break? Can they go without too much disruption to the training session and so on? And then maybe some practical considerations directly for research. As I've said already, that it can be difficult to recruit some of these players. So for example, if we want to study heavy menstrual bleeding, it means we need to collaborate with a lot of clubs because there won't be sufficient players within one club to do a study. So in order to get maybe even a sample size of 10 players with heavy menstrual bleeding, it means that researchers may need to go even to 10 clubs to get one player per club, for example. So recruitment can be difficult. And also when we think about maybe studying the effects of heavy menstrual bleeding on performance within football, we might actually question ourselves and say, well, instead of studying the effects of this on performance, do we not have a duty of care to make sure that actually that we work with those players so that they have their heavy menstrual bleeding is well managed, they have the right medication, the right products. And actually, if we have the duty of care really correct and right, then perhaps there won't be any effects of heavy menstrual bleeding on performance. So quite a few practical things there to consider about, I guess, from the player's perspective, the club's perspective, and from quite a specific research perspective. I do want to share one research example with you. So this is a survey. It's not specifically from football, but it is from elite women athletes. This survey conducted in 2020, so quite recently. Of course, with surveys within research, there are sometimes some considerations that we need to acknowledge. So, for example, there may be some bias in the sampling, in the recruitment. So, again, if you're a player who with suspected heavy menstrual bleeding or with diagnosed heavy menstrual bleeding, you might be more likely to take part. And of course, in that sense, then we might inflate the numbers a little bit. So, thinking about surveys, some of the other things may be around the fact that it's often self-reported. So, maybe the conditions are described by the players themselves and are not confirmed by medical personnel. So just a couple of the quick considerations when we are considering survey data. But in this survey, they showed that amongst women athletes, that the athletes did seem to have a higher incidence of heavy menstrual bleeding when you compare them to their non-athlete controls. So women of a similar age who were not engaged within elite sport. Some other findings which I think are very interesting. So if they have more incidences of heavy menstrual bleeding within elite sport, what does that mean for performance? Well, they looked here at quality of life, so maybe more indirect measures of performance. And actually athletes were self-reporting, an important point, better physical quality of life, but actually they had higher perceived stress scale levels. So actually a worse mental quality of life. So actually two things there in opposition. And so we would need to think about, with these two things possibly in opposition, how does that manifest in any changes in performance? And actually this survey didn't go on to cover that, but it gives us a sense of that perhaps this is an issue that we need to look at the incidence rates in elite football in particular. So we have data sets directly for football, but then we need to think about, well, if there are changes in physical and or mental quality of life, do they manifest in changes in performance? So lastly, just to try and draw this together in terms of our case study, for sure, we need more high quality research. For a long time, when considering women, we said we needed more research, but actually we need to also consider the quality of research within this space. It can be difficult sometimes. For a long time, we've not researched women athletes. And so therefore, if we're not really embedding that in our, say, sports science degrees, then we're not actually really training the researchers of the future. So we really need to look at every aspect about research and how we train people in this space. So we need more high quality research. As you'll have heard from some of the, I guess, more practical side of it, we need this topic of heavy menstrual bleeding to be discussed openly within clubs. So for a long time now, we've been saying that the menstrual cycle is one of the remaining taboos within sport. I think this is no longer true. I am really feeling better about this topic. As I say, I've been in this area 25 years, and I think in the last 5 years, I've seen a real change in the culture. But of course, now that we're speaking about menstrual cycles more generally, we have to push now even further into some of these quite specific, maybe types of menstrual dysfunction. So if we can talk about it more openly, I think that will help. As Emma showed us, we definitely need to have some screening questions. We need to ask the right questions, and more than that, to have good follow-up questions to understand the whole environment. And we need to be able then, if we have a suspected case of heavy menstrual bleeding within a club with a particular player, we need to know who to send them to. Coming together, that means that within the club environment, we need good resources. So whether that might be free sanitary products in the toilets, it could also be consideration around supplementation. I mentioned about anemia, for example. So it could be, or it should be, that we use a multidisciplinary approach to handling cases of heavy menstrual bleeding within elite women's football. And then we need to think about quality of life. That survey showed us that there could be changes in physical or mental quality of life, and how that then may affect the player's ability to perform. And when we speak about performance this evening, we're talking about both training performance, but also competitive performance. So Evert, I will hand back to you to maybe take some questions on this case study.
Yeah, sure. Thank you for this first case study. Very, very interesting. There is one question in the chat where I will get to quickly. I wanted to ask something. I heard some terms. What is normal? And then there was also the term dysfunction, and Kirsty, you said diagnosed somewhere, which makes me think there's a thin line between what is normal, heavy menstrual bleeding, and what is abnormal. When, this is a question for both of you, would you start to be worried where it becomes really an issue for the player?
Shall I start, Kirsty?
I think so.
We ask the patients or the ones who come at my outpatient clinic to fill in like a scoring list where I can see how much blood loss they have every day. And normally you see that the first 3 days of your menstruation, of your period, the blood loss can be a little bit more, and after that it gets less. A period can last for like 7 days. That's normal. And the mean blood loss is about 80 milliliters, which sounds not too much, but most of the time it's a lot of fluid you lose as well, but it's not full blood. But for sure, this is very difficult for patients or to see how much it is. So that's why we have a PBAC score, and this PBAC score gives me an indication of how much it is. But sometimes we just say, if you experience it's heavy, you need to do something about it. So also the experience, we need a combination of the amount of blood loss and the experience.
Okay, that's clear. Kirsty, you want to add something?
Yeah, well, I mean, of course, Emma is the clinical expert. I guess more within a club environment, as I say, it could be that some players have heavy menstrual bleeding, but are not sure. So, of course, by the time they get to Emma, they're already thinking it's possible for them. So I guess within the club environment, the only thing to add is if we change the culture, if there's a willingness to discuss these topics, then we may find people or players with heavy menstrual bleeding coming forward and knowing who to speak to in the club. So, who is the person they should go to? Some clubs, of course, have a clinician, a medic embedded within the club. Not all clubs, of course, depending on the facilities and resources. So it's just knowing that, who should they speak to about this in the club? Are the players speaking about it to each other? And then just thinking about, what's available to them. So somebody to speak to and get signposting to people like Emma, but also, again, what facilities they have to maybe deal with this issue. So they can, when they have a diagnosis, how do we make life better for them within the club setting?
Yeah. Okay. Thank you. One question in the chat also on this case, and then before we move to the next one, there's Jan van Asseldonk asks whether it's maybe, apart from awareness, also an option to give intravenous iron. Maybe this one is for you, Emma.
Yeah. Thank you so much for this question. You have various options for heavy menstrual bleeding treatments. In the first case, I want the bleeding to stop before we start giving supplements. So iron intravenous or by tablets is a possibility. We see a little bit more reaction when you put it in an IV drip, so intravenous. But that's an option we give to patients very often. Everything has its side effects. So in the first place, I think we need to cover why somebody's having this menstrual bleeding and treat what the reason is. So diagnose it and find the reason. And then if you want to get a quick iron transfusion, then this intravenous option is a very good one. Yeah.
Okay. So I think this was enough for this case at the moment. So I'll quickly move it to the next case. So I'll give the screen back to you, Emma, and then I'll leave you for a few minutes.
Thank you so much. We will go on to case 2. I have seen a 24-year-old woman. She's a professional international football player, and she comes to my clinic because she lost her periods. This is called amenorrhea, and then amenorrhea means that you haven't had your periods for 6 months or longer, and this is abnormal. I want to know a lot of things when you come to me when you have this amenorrhea. I want to know, for example, how were your previous periods? So before this 6 months, were they regular? Were they irregular already? Have you ever had normal periods? An amenorrhea can also mean that you're pregnant, because then you have an amenorrhea as well. So I want to check if you're not pregnant. We see amenorrhea when you lose or gain weight very easily or fast. So I'm checking your body mass index and asking you about your weight loss or gain. And there are a few things which could cause amenorrhea as well, which will give some signs through the body, which can give me information. So, for example, galactorrhea, which means that you have some fluid loss from your breasts, but also hirsutism, which means that you have a lot of black hairs all over your body, more male-like. And of course, again, it's very important to know if you use any contraceptive medication, especially hormonal contraceptives, which could influence an amenorrhea, so not having this menstrual cycle, but it could also cover problems. And since we know that, let's say, if we've checked all these things, we make an inside ultrasound to see if your uterus and ovaria are normal of size. And if we have some signs which could declare one of the points that I mentioned over here, and we do laboratory blood tests, which can exclude some of the reasons which I just mentioned. But in sports, we very often see one or two main diagnoses when you have an amenorrhea, and Kirsty is going to tell us a bit more about that.
Thanks, Emma. So I want to just quickly show you a visual representation of what amenorrhea looks like and what it is compared to a normal healthy menstrual cycle. So if we just take a few moments on this slide, if please you take your eyes to the figure which says ovulatory. This shows the menstrual cycle as it should be. So here you can see estrogen is in red and progesterone is in blue, if we just concentrate on those two hormones specifically. And so they have this pattern, and you can see little red arrows at the start of the cycle, which shows that this player is menstruating. And this cycle length can be somewhere between 21 and 35 days and is considered normal. And so if you then look at the end of the figure and it says amenorrhea, you can easily see, firstly, there are no red arrows. So as Emma said, this player is not menstruating regularly and has had an absence of menstruation for many months. And estrogen and progesterone are clearly, you can see from this visual, not presenting as they should be. Now, for a long time, we said that amenorrhea was an early warning detection system in female athletes to say that something could be wrong. What I just want to show you here briefly is that actually there are other types of menstrual dysfunction which may happen along the way. So actually for some players, we move from ovulatory to amenorrhea quite quickly, and others take longer. And for some of those who take longer, we can see some various steps. They don't always occur discreetly like this and in this order. Sometimes some happen at the same time. But actually what we might find is that if we look at ovulatory and compare it to the picture next to it that says LPD, this stands for luteal phase deficiency. Here the cycle length is still the same, somewhere between 21 and 35 days. This player is still menstruating regularly, but for those who are quick with their eyes, you can see the blue line for progesterone is not the same. And so this shows us maybe the importance of not just looking at the regularity of menstruation as the important thing within elite sport. We should also look at maybe how progesterone is doing, because luteal phase deficiency can be somewhat hidden. So you wouldn't know necessarily that you had this slightly altered picture. If you look to the figure next to it, which says anovulatory, again, cycle length is fine. This player is still menstruating regularly, but here you can see that neither estrogen or progesterone are behaving as they should do. And again, this can be a hidden type of menstrual dysfunction. Because they're bleeding regularly, you could make the assumption that they've got that lovely ovulatory picture. If you look at the next one, so this is actually stepping up in the picture. So these are oligomenorrheic cycles. So this is the first time you get a slightly, a more obvious hint that maybe there is dysfunction. So here the cycle length is longer than 35 days. You can still see that there can be ovulation within these longer cycles, but actually if you look at the anovulatory version of oligomenorrhea, not easy to say out loud, very difficult to write down and spell, but if you look at this picture at the very top of the screen to the right hand side, you can see that the picture there of the hormones is absolute chaos. So this player could be menstruating somewhat regularly, so maybe 36, 37, 38 days at a time, so not amenorrheic, but you can see that their hormonal profile is completely chaotic and not the same as the ovulatory picture. Of course, as the cycles get longer and longer and longer, then we inch towards amenorrhea, and that's the picture that you get. So I think it's really important that while we're super interested in amenorrhea, that maybe if we look to track the menstrual cycle to a deeper level, that we might actually see some of these dysfunctions before our player arrives at amenorrhea. So we might be able to prevent some amenorrhea in some cases. I just want to quickly show you, this is a data set from a recent systematic literature review. It shows, if we just look at the primary amenorrhea and secondary amenorrhea, you can look at the number of studies which looked at this. I haven't got my glasses on, so I can't read those numbers. They're too small for me. Hopefully you can see them. But you can see the relatively small number of studies which are reporting primary and secondary amenorrhea within female athletes. They then nicely split it up into adults and then adolescents, because we sometimes associate, particularly of course primary amenorrhea, that's when you have that delayed first period. So when they're older than say 15 or 16 and they've not yet had their first period. So of course we might expect to see a little bit more primary amenorrhea in adolescent players, and then we see more secondary amenorrhea in adult players. So just something to consider to see what is the prevalence within female athletes. Again, please remember this is not specific to football, but it could well be that that is where a future study may look at the incidence of both of these conditions. And then lastly, you might think that I've just put up the same slide again that I did when it came to heavy menstrual bleeding, but they're actually similar issues. We need more high quality research examining either the incidence and then the effects of amenorrhea on performance, whether that's either training performance or competitive performance. But of course, we also must think of that duty of care. Rather than researching it, do we need to actually work to prevent it and have useful interventions? Again, if we change the culture within elite women's sport and within football, we should have an openness about this topic. So again, if you have a player within your club, do they know who to present this issue to? If you have a medical doctor, of course, that might be the obvious choice, but sometimes these are conversations that an athlete might have while they're getting some treatment, and so they may speak to the physiotherapist about it. It could be something they speak to the strength and conditioning coach about as they're working out maybe in the gym. So again, thinking about a multidisciplinary approach to this, an openness, really open conversations within the club, and then knowing how to screen for this. So how often do we ask the players about their menstrual cycles? If we ask once a year, well, maybe they were ovulatory at the start of the year and 7-8 months in they're amenorrheic. But if we don't ask them again then till month 13, we're allowing them to be amenorrheic for a very long time. So thinking about when do we screen, what questions do we ask? So thinking about the questions that Emma showed you, and again, who do we signpost our players to? So if they're telling us that they've not menstruated for 6 months, who is it that you send them to? So again, having that pipeline of care, and then thinking about possibly the long-term health implications of amenorrhea. So we really do want to identify people before ideally they become amenorrheic, but if they are amenorrheic, how long has that been the case, and what are we doing to return them to that ovulatory cycle? So that's from me. So back to Evert for some questions on this case study.
Well, back to the three of us, I'd say. So if anyone has a question, please put it in the chat relating to this. I have a question that maybe relates to a question on red screening that was posted in the chat. You just alluded to it, Kirsty, as well, prevention. For prevention, you need to know something about risk factors. It's nice to see all these graphs with dysfunctions. Well, not nice actually, but it illustrates the case well. Instead of monitoring and diagnosing early, what can we do to maybe prevent athletes from getting into a dysfunctioned cycle?
Oh, that's a big question.
Maybe a smaller question. Do we know about any risk factors? Let's keep it at that.
Okay, so I think the obvious risk factor that possibly a lot of people on the call are thinking about is around low energy availability. So of course we know that if the body is faced with the challenge of low energy availability, so insufficient energy to do everything, the body is clever, maybe makes a priority of, okay, we're going to fuel today's training session, of course, brain function, heart function, etc. And so it works its way around the body and says, okay, well, today I'm not pregnant, we don't need to have a baby today. And so it turns off or sacrifices the reproductive axis. So of course, the obvious risk factor is if that is the case, if low energy availability is an issue, that could be the result. So I think raising awareness around good fueling, and not just, eating enough, but eating enough carbohydrate and so on. And so there's been some studies recently published around possible fear of carbohydrate within elite women's football. So that study specifically from football or soccer, sorry, depending on where you are in the world. But I think, that would be the obvious one. And of course, then as Emma said, things like pregnancy, it used to be 20 years ago, the first thing that would happen is a pregnancy test, and now that's almost forgotten about. And if I can, maybe one more thing as a risk factor that I would mention, just because we recently did a case study on this, is around stress. And so we worked with the player and who was amenorrheic, and we of course thought low energy availability, did a big piece of work around fueling. She may have been the best fed player in the WSL, but actually didn't return, her periods did not return. And cutting a long story short, actually her periods came back after she moved home to her own country, an international player, clearly a little bit homesick, a lot of stressful situation, being away from home and so on and so on. Of course, we can't say that that's the actual cause of this, but in terms of an observation, when some of those stressors were taken away, then for her periods came back. So I think for me, it would be low energy availability, stress, and pregnancy would be the three that would come to my mind first. But there are many others.
Yeah, exactly. All these are very good. Kirsty, you mentioned, I think, the most often seen in female athletes, but in the outpatient department, I also see, for example, polycystic ovarians, which cause oligomenorrhea or amenorrhea, and this is a really different kind of cycling disturbance. So it's really, you need to have blood laboratory tests to find out which is the cycle disturbance and what's the cause, to solve it and prevent for further harm.
Yeah, obviously there's also a difference in just general risk factors for dysfunction and sports-related risk factors in relation to dysfunction. That's maybe something to highlight. Here's a question for you, maybe, Emma. What can be done to return players to the ovulatory cycle? Is there any insight you can share on that?
Thank you for the one. Well, what can be done? You need to find out the cause, because if you're not having an ovulatory cycle, I cannot resolve it or help if I don't know the cause. So that's the first thing I want to know. So I'm going to ask all the questions I just showed you. I'm going to make an inside ultrasound to see if your uterus and ovary has a normal size, normal follicular size, normal amount of follicles. And if yes, if everything is normal, then I would do a blood test. This will divide for me in if there's a relative energy deficiency syndrome, or if you have, for example, polycystic ovarians. And both conclusions or diagnosis will be treated differently. So return players back to the ovulatory cycle is really depending on the cause, I would say.
Thank you. Then there's one more question that we can post here. Whoever wants to answer this one gets to answer this one. Is it okay if players ask, and this one is in two pieces, to sometimes give them medication to delay the menstrual cycle? Here it is. So this is the second part of the question.
Shall I answer this question?
Go for it.
Yeah, I don't prescribe anything. I'm a
Okay,
PhD
good.
doctor, so you're the real doctor.
I do give medication to delay a menstrual cycle. For example, when they experience heavy menstrual bleeding or when they experience very heavy abdominal pain during their period, which could which could influence their performance. I would discuss with the female athlete what she wants. Everything I give has sometimes side effects. It depends if you want to give it only for this game, for this match, or you want to continue with having something if you're having other problems. But cyclocapon, which is mentioned over here, will not delay the menstrual cycle or your period. It will only decrease the blood loss if you have heavy menstrual bleeding, because it influences your blood amount, but it's not a hormone, so it will not give you an ovulatory cycle, or it will not stop your period.
Question answered, I guess. So also given time, let's move to the last case you have prepared for us. Here's the screen, and I'll see you again in a few minutes.
Thank you again. I really like all the questions. Thank you so much. Here's our last case, case 3. This 25-year-old woman plays on the national level, and she comes to me. I've seen these consultations more often the last month because she wants to have contraceptives. And the reason for her to have contraceptives was because she thought that it would maybe prevent any injury. So to continue, what do I want to know as a doctor when somebody comes to me with a contraceptive question? We start again that I'm asking you all the questions about the period, about your menstrual cycle, the length, how much blood loss you have. I want to have your history. What kind of medication did you use before, or which kind of contraceptive medication? Were there hormones, or was it non-hormonal contraceptive medication? And what was the reason for using contraceptive medication? We do know that 50% of the female athletes who I've seen in the Netherlands do use contraceptive medication for a non-contraceptive reason. So it's not because they don't want to get pregnant, which its definition is to use it for, but it's used because of, for example, heavy menstrual bleeding or abdominal pain, or they think it would help them for preventing injury. And we know a little bit more about that now. Last couple of years, some research has been done. So nowadays, I would not advise to give contraceptive medication, hormonal contraceptive medication, to prevent, for example, from anterior cruciate ligament injury. And Kirsty is going to tell us a bit more about this.
Okay, so before we go directly to the injury, I think it's interesting, like Emma said, to think about how many of female soccer players, female football players are using contraception. So this is a study, recent study that I was a part of, and it's again questionnaire based, so it comes with all of the same things around sampling bias potentially and recall, and it's self-reported and so on. So keep those things in your mind. But we asked a quite large sample size, and this is from the Women's Super League in the UK. So 75 players responded. Around 25 of them, 25%, reported current hormonal contraceptive use. And so actually, when we compare this to other sports, so we've done the similar type of survey within, say, Olympic sports, this number is actually quite a bit lower. So normally we see almost a 50-50 split, so slightly lower in this particular sample. Of course, remembering that this is a survey is a bit like taking a photograph. It's a moment in time. Maybe next week the numbers change entirely. But you can see that many more had used hormonal contraceptives previously. So what this tells us is that we need to do this type of audit quite often because the profile changes. So at one point, maybe 43% using, and then it drops to 25%. So of course, it's interesting for us to know what is the reason that they have discontinued use. The combined hormonal contraceptives accounted for the majority, so around 62% of all of those used, and then progesterone only making up the remainder. Now that makes it perhaps look like there are only 2 types of hormonal contraception. There are many types. This means that some of them are combined and they could be delivered in via a pill or some other mode of delivery. And then we have the progesterone only, which are we call long-acting reversible contraceptives, and they could be more like injections, for example. So lots of different types here, but we're just taking a simple view of combined, which contain 2 hormones, versus progesterone only, and by definition, just containing 1 hormone. What's interesting to us is that when we asked these hormonal contraceptive users to tell us a little bit about their experience, so did they feel like they were regularly experiencing some adverse symptoms? And again, this word it can be a little unclear, but the better word here is side effects, because actually, as Emma said before, that when you take a type of medication or something that's exogenous, so external from the body, that can sometimes come with a different experience, so changes in physical and or emotional well-being. And so actually 38% are still saying that they have some negative experiences, and the number is much higher in progesterone only hormonal contraceptive users. So again, from a practical perspective, we would be thinking, why are they not speaking to the club doctor or going to speak to somebody like Emma? Because actually, given that there are so many varieties, combined progesterone only, pills, injections, implants, all of these different modalities, why are they not speaking to somebody about possibly changing the one they're on so that they can have a better experience? 86% did report benefits, and again, these are perceived benefits associated with their hormonal contraceptive use. Some around pain management. I mean, again, thinking about what Emma said, we were expecting a lot of them to say the advantage is contraception, but actually they talked about pain management. So perhaps these were players who had a lot of problems with their menstrual cycle, so they swapped that profile to this profile, and so they found a relief in pain, but also a lot of them, the majority of them, saying that they liked the ability to predict and control their cycles. So for example, if they were a pill user who were using the pill for 21 days and having 7 pill-free days, they knew when they were going to experience that withdrawal bleed. So that ability to do that. And of course, we mentioned one of the last questions was around medication to delay or prevent menstruation. So here, maybe in this example of the pill users, they would just maybe skip the 7 pill-free days, go on to the next pill packet for the 21 days, and then they would bypass that withdrawal bleed. So from a survey like this, very simple to do and simple questions to ask your players, but actually you can get quite a lot of useful information from this. Apologies that something seems to have gone slightly wrong with this slide. It didn't look like that earlier, but what if you concentrate on the left-hand side of the figure for a second? This represents a recent systematic review and meta-analysis around the effects of oral contraceptives on exercise performance. Now, exercise performance is a very superficial term. Again, I'll apologize. This is a general term. It's not football specific, but we looked for studies that had some either performance test or a test that might of something that might underpin performance. So for example, there might have been some strength testing or some fitness testing and so on. And so if you have a look down that side diagram, you'll see that actually there aren't a lot of studies in this area, and of the studies, if we look at the other very strange diagram that doesn't appear exactly as it should do, this talks about the quality. And so this goes back to a point I made earlier. We don't have a lot of information, and the information we have is not particularly high quality. And so if you look at the diagrams on the right-hand side, and particularly the solid black line, if you look at the 4 bars, look at the one on the most right-hand side with the little black bar, that represents the number of high-quality studies. And all of the other grey bars that are stacked on top of that represent moderate or low or very low quality studies. And just you can see visually here that the high quality studies are in the minority, and the other quality levels are in the majority. So actually, when it comes to trying to understand the effects of oral contraceptive pills on aspects of exercise performance, we don't have a lot of studies, and the studies that we do have are often not high quality. If you do want to read this full paper to understand more about this topic, this paper is open access, but I can conclude for you, I can save you a long read. And actually, with the way that it is, we have insufficient high quality evidence to really make a conclusion. So right now, we would not tell football players or any women engaging in sport that it's either an advantage or a disadvantage to use oral contraceptives. And so actually, this one is particularly on exercise performance, but you could swap out things around nutrition and other outcomes that you're interested in. And that also includes injury. So taking it back to the idea of injuries, we have insufficient high quality evidence to really determine whether or not oral contraceptives either are a benefit or a disadvantage when it comes to injury rates. So again, it's not the same slide. It has many of the same points, but of course, I'm going to say we need more high quality research, and hopefully the people here on the call in the audience, you're going to hopefully commission some of this research, this high quality research within a football setting, so we can really understand women's football. Again, we need to talk about these topics within sports. So in the club, it would be good, again, to have somebody designated within the club that the players can speak to. Okay, I use this type of contraception. I'm not sure if it's the best one for me, and be able to look at that. So do this type of auditing and screening, and then signpost to professionals like Emma to get advice. And again, it isn't just advice on which type to take, but we have players who want to talk about either going on to hormonal contraception for the first time, but maybe also about coming off it. So if they come off a hormonal contraceptives they've been using for maybe 5 or 10 years, what can their experience be? When will their menstrual cycles return? What can they expect? If they had some issues with their menstrual cycle 10 years ago before they went on it, can they expect those sort of issues to still be there? So a lot to think about. And really what we want to do is we want to give the players some agency to make really informed choices. You know, which is the right type for me? Should I be on it? Should I come off it? And I think it's really important that whilst maybe we think sometimes about the effect of hormonal contraceptive or the possible effect they might have on performance or injury or nutrition or recovery or any of these things, we really do need to remember that hormonal contraception is a woman's right to choose. It's something that is also important away from sport. And so actually we need to make sure that, you know, unexpected, unplanned pregnancies, you know, we have to give the athletes, the players, the right to make this choice for themselves. And then we can go to other things around if it's managing menstrual symptoms or whether or not they're using it to have a predictable experience and a predictable hormonal profile. So a lot to think about, but these are some of the things that we'll be thinking about both in practice within clubs, but also from a research perspective. So Evert, back to you.
Thank you for that last case. This brings maybe immediately on the screen a question that has been burning for a while already in the chat. And that's on injuries in the menstrual cycle. You just mentioned the word Kirsty. So this might be the perfect time to see if we can answer this question, which is a rather big one, I think.
Yeah, it's a real hot topic. Everybody is speaking about this. Yes, we're all thinking about a particular ligament, right? I'm going to answer almost twice from a research perspective. So looking at the evidence, the research evidence that's available to us. Actually, it's one of the areas where there are many studies published, laboratory studies published. So we have more studies in this area. We do still have problems with the quality of the research. We also have the biggest problem, I think, for me is that the majority of research on ACL injuries and ovarian hormones, so menstrual cycles and pill use, for example, they're not done in elite athletes. So we find the translation of these studies, so they're very laboratory based, they're not in elite athletes, and so we don't really know how to translate this into the space. So there's still no consensus from the research evidence. So that's one way to put it. Another way to put it around injuries in certain phases of the menstrual cycle is when we have players now getting ACL injuries. I think most clubs on the call, you can give a little thumbs up if you do this. Probably one of the first questions you ask is, what phase of the menstrual cycle are you in? Or do you use oral contraception? And it's a question that we're asking routinely now. And actually, we're not seeing any association between a particular phase of the menstrual cycle or whether or not they use oral contraceptives and ACL injuries, for example. So bringing that to summarize, I think within the research space, there's no consensus. We still have issues around who the research is being performed on and the quality of that. So no consensus from a research perspective. So I think that's good news. So we can go back to the players and say, you don't have to be worried right now. There's not an injury phase. And then from the anecdotal, I think maybe anecdotal is the wrong word, but from the evidence coming directly from the field, in my experience in the clubs that I am really fortunate to work with, we're not seeing again these injuries happening in just one phase. I think we would all agree that any type of injury is usually multifactorial, and I think we need to be pragmatic. So my answer to this is no, not a particular menstrual cycle phase. And I would encourage you to tell your players this, because I think there is real anxiety right now, and a lot of it being driven around with social media. And it's interesting, they all think they're going to have this injury when they've got their period. And if you did look at the research evidence, that's not the lab, the phase that they're seeing in the lab. So there's a contradiction there. So sorry, slightly long answer. It's nuanced. There's a lot to consider, but my answer is no. I should have just.
Oh, good. I think you answered. No. I think you answered the next question as well. Then, which adapted training sessions to the phases of the cycle?
No, not at all. And actually, that would be really difficult to do as well, especially within a team environment. So I don't think that you don't need to. There's no research evidence to dictate this. If the evidence changes, wow, we're going to have a really hard time trying to implement that. But no, there's no need to do that right now.
Thank you. Can I also look at you, Emma, for an answer to these questions? Kirsty and myself have more of a sports scientist hat on. You have a more clinical hat on. What is your take on this?
Thank you. Yeah, thank you also, Kirsty, for this nice summary. Well, I do see a lot of female athletes with this question, especially in team sports. As Kirsty already told, there's anxiety around it. And what I always tell them is that they need an individual advice. And for that, they need to go to someone who can give that to them. So, for example, general practitioner or gynecologist, it doesn't matter to me, but you go to somebody who can give you this individual advice. Because what I do think is that if you're having, for example, a lot of pain during your period, this could influence the risk of your injury. Since pain is causing, for example, being less concentrated. So for this reason, you can come to me or come to another doctor to talk about. But still, this really needs an individual advice. So I wouldn't say to all football players, just use the contraceptive pill because this will work. This individual advice is, I think, the way I look at it.
Perfect. I think for the sake of time, we have to leave it here. I truly enjoyed this. It was a really nice setup to have the two of you explain the cases and have the people actually in practice ask us the questions that matter to them. And I think we answered nearly every question that was popped up. So thank you so much for today. Maybe one quick question, maybe you can give an answer in one quick sentence. Research was mentioned a lot. What is the main research topic we need to focus on to bring a dent into these issues we have around menstrual cycle? Emma first, maybe.
Difficult. There's so many topics which are very interesting, but I think that knowing the incidence of cycling disturbances, which could give better advices to individual athletes, would be my research focus.
Okay. And Kirsty?
Yeah, mine's pretty much the same. I think we need to develop a way to identify each player's ovarian hormone profile, and because we keep talking about taking an individual approach, so how do we establish these profiles within the high performance network, so within elite football, so that we can then tailor any response to that. So agree with Emma.
Perfect. Well, that's full circle, I think, back to where we started, that we're working on a consensus out of the UEFA medical department on exactly these issues. What can we do with the current evidence available? What should we do and how should you do it? Of course, there's a lot of white spots, and for that, we need the clubs and the teams that are online right now to help us out to fill those. Thank you all. So before everybody logs off, I would like to invite you once again to consider the UEFA Medical Symposium next year, February 4 to 6, 2025 in Lugano in Switzerland, around the Women's Euro to get there. And then our next webinar is, again, the last Monday of the month, April 29, and we're going to talk about tournament well-being. And of course, that is in relation to the build-up to Euro 2024, where in the tournament, a lot of doctors will be faced with keeping care of their athletes while in the tournament and having a dense match schedule. So I hope to see you then. Thank you also to the European Club Association for supporting us in this. And until next time.